Musculoskeletal disorders in children birth to 5 years of age. Musculoskeletal disorders can affect the skeletal muscles, tendons, bones, joints, and ligaments. Common musculoskeletal disorders in children birth to 5 years of age: bowed legs, Blount's disease, knock knees, flat foot, elbow radial head sublation, also known as pulled elbow or nursemaid's elbow, transient synovitis of the hip, septic hip, developmental dysplasia of the hip, and idiopathic clubfoot. The highlighted musculoskeletal disorder is idiopathic clubfoot. I was inspired to write about this topic because of a child who I encountered in an ECSE classroom with the condition. So clubfoot is recognized at birth and the child is immediately referred to a specialist. There are many supposed genetic causes for clubfoot. One researcher said it's an intrauterine position and a genetically predisposed fetus that causes it. And then there's another theory about clubfoot being the result of a germplasm defect. Both of these theories imply that there's a hereditary factor that is involved in the cause of clubfoot. The gold standard treatment for clubfoot is the Ponseti method, and this is globally. It is administered when the child is 2 months old, and series of sessions where the practitioner manipulates the foot with a casting molding that fits the entire leg from the groin area and is molded around the foot. The casting is changed every 5 to 7 days until there is a correction of the position of the foot. The child is then given a brace to wear for further correction, and the purpose of the brace is to promote standing and gait ability. Standard treatment requires the child to wear the brace during the day and night for 3 months or until the child can begin to pull up to stand. Then it is only worn overnight and during nap time until the age of 4 years old. But there is still research being done on how long a child can continue to wear a brace. Findings in literature review for idiopathic clubfoot and developmental domains. In the literature that I've read, here is what was found in those research articles: that idiopathic clubfoot has not been shown to affect joint attention skills in children, that children with clubfoot had risk of gross motor limitations, children with clubfoot had age-appropriate fine motor skills, cognitive functioning testing showed a slight impairment as it relates to visual spatial memory, and Swedish researchers are exploring the possibilities of delays in expressive language along with other disorders such as attention deficit disorder and autism in children born with idiopathic clubfoot. Evidence-based practice to support children with idiopathic clubfoot. I decided to go with research that took a holistic approach that addressed the needs of families with children with idiopathic clubfoot. One main research that I found discusses culturally sensitive care as a form of support to families with children with idiopathic clubfoot. The study notes that parents were finding it difficult to handle the multiple treatments that are involved in correcting clubfoot. So Zontz took it a step further and conducted a study and found that inconsistent brace use is highly correlated with relapse. So his study found that allowing time for parental education can result in families coping positively with effective treatment outcomes. In the same study, Morin suggests healthcare providers to create culturally sensitive communication to families that can reduce recurrence for children treated with the Ponseti method. The suggestions included positive reinforcement, praise for compliance, and avoiding negative comments or threatening surgical intervention. In the same study, Shea mentions another study by Zons that focuses on gait analysis and parental concern. So the studies suggest a way to evaluate motor milestones so that parents will know the progress of the clubfoot treated with the Ponseti method over time. Accommodations for children with idiopathic clubfoot. Safety training on the playground, hallway safety, assistance with physical needs like toileting and dressing, sessions for body positioning and seating, fine and gross motor support, adaptive technology, walker or other standing supports, attention to students' physical needs when developing a school emergency evacuation plan, considerations when planning field trips and school activities. As for medical and developmental pathways, it requires a family to diligently comply with treatment requirements. Success can be achieved by providing support to the families using some of the suggestions outlined in the evidence-based practice models. The models are useful because they promote advocacy and collaboration between healthcare specialists, parents, caregivers, and even educators. Healthcare providers can properly inform parents of the treatment process and allow ample time for planning on how to cope with multiple treatment sessions. Early intervention members can collaborate with the family to begin setting goals and providing the appropriate services that will enable the child to transition to their next learning environment. ECSC teachers, that's us, can continue the progress by creating a professional learning cohort focused on issues of care for the child. Efforts to promote further progress can reflect in culturally responsive instruction that includes developmental goals. Thank you very much.